Everyone. You can all now see my screen. Okay, we can let everyone in.
Shall we begin? Hi, everyone. Welcome to our panel event, Medication Abortion in the Digital Age. We are so excited to see such a large crowd and people from so many different states attending today. What a great turnout. Thanks for joining us. My name is Lindsay Parham, and I am the Executive Director of the Wallace Center for Maternal, Child, and Adolescent Health. For those of you who aren't familiar with us, the Wallace Center is a multidisciplinary research center in Berkeley School of Public Health. We conduct actionable research in innovation and technology to advance maternal, child, and adolescent health and reduce inequities. Today, we partnered with our fabulous Center of Excellence and MCAH here at Berkeley to put together this event. The Center of Excellence provides graduate level training and education in maternal, child, and adolescent health research and practice. They prepare students to be the future leaders of MCAH through exposure to the knowledge and skills needed to build public health capacity, practical experience, and collaborations with communities and Title V partners. While I'll be moderating the discussion today, I'm assisted by Jess, Emma, and Amarutha, who will be working on IT and chat to keep things running smoothly. If you have any IT questions, please chat them directly or email jessica_ross@berkeley.edu. And just a reminder that this event will be recorded and we'll be emailing the recording, resources, and slides following the event. So please send your questions as they come up to the chat and we can start. Next slide. So the goals of today's presentation are to provide a better understanding of what medication abortion is, that it's available, and that it's safe. A better understanding of the potential legal and privacy risks involved in procuring medication abortion, a better understanding of how to talk about or message about abortion, and understanding our current situation in the US within a historical and international context. Next slide. So today we're joined by a great group of experts to help us unpack this complex and timely topic. Slide 3, please. And after I do a very brief background discussion of what medication abortion is, we'll hear from Amy Merrill, the Digital Director and Co-founder of Plan C, Linnea Pittman, an associate in Morrison Foerster's Privacy and Data Security Group, Katie Woodruff, a social science fellow in reproductive health and maternal health at UCSF, and Ndola Prada, a public health physician and medical demographer at UC Berkeley, the Fred H. Bixby Endowed Chair in Population and Family Planning and Director of the Bixby Center for Population Health and Sustainability. Our panelists are going to provide an overview of their topics to lay the groundwork for a discussion amongst the panel, after which point we'll move on to Q&A from the audience. Next slide. So, a little overview of medication abortion for those who are not familiar with it. It consists of mifepristone, which works by blocking progesterone, which is a hormone needed for pregnancy to continue, and misoprostol, which is taken 24 to 48 hours later and induces contractions to end a pregnancy. It's most commonly recommended for use up to week 10, and it's very safe. Next slide. So since medication abortion was approved for use by the FDA in 2000, its use has steadily increased, and it now accounts for over half of all early term abortions. But the public and political discussion around abortion in the US until recently has rarely covered the use of medication abortion. Most of our discussions center on the availability of it within a physical clinic or a doctor's office. In fact, many people in the US confuse emergency contraception, which is also known as Plan B, for medication abortion. Next slide. But with clinics in many states closing after the Jackson v. Dobbs decision in June and the end of Roe v. Wade, early term surgical abortion is far less available, and medication abortion is gaining importance. In states where it's not banned, medication abortion can be accessed within the medical system by an in-person visit to a provider or a telehealth visit with a provider. But unlike surgical abortion that must take place in person, people can also get pills on their own and take these pills on their own, which is called self-managed medication abortion. But getting information and medication for abortion in 2022 usually means going online, and that can leave a digital trail. As you can see on this map from earlier in October this year, the United States right now is a patchwork of different laws with varying legal frameworks regarding abortion and telehealth. Some of these might create legal risks or barriers, and at a minimum have created a lot of confusion, chaos, and fear on the ground. Next slide. So this is our topic of discussion today, and we hope you take away from this next hour these 4 points. And starting our off today will be Amy Merrill, the digital director and co-founder of Plan C, discussing her work and all the on-the-ground issues that she's coming up against with the work that she's doing with Plan C. Okay, Amy, are you ready to take us away?
I am. Thank you, Lindsay. Hello, everyone. Thanks so much for having me. My name is Amy Merrill. I use she, hers pronouns. I am based in California, and I serve as the co-director, co-founder of the Plan C campaign. I'm also a UC Berkeley alumni, so it's a real honor to be here today. I studied English and music long ago and went on to study nonprofit management, which led me into anti-human trafficking, human rights issues, and gender issues, and eventually to starting Plan C in 2016. So next slide. I was going to start us off with an animation that we released last month in collaboration with a filmmaker and an animator. It's a good snapshot. We don't hear the sound.
Did you know
Yes.
abortion pills, also known as medication abortion, have been FDA approved since 2000? They are recommended for ending an early pregnancy up to 12 weeks, and they're safe for self-managed use. Abortion pills have become common and more accessible all around the world. 93% of Sweden's abortions are with pills. In India, 70% of abortions are self-managed outside the medical system with pills. As of 2020, medication abortions account for the majority of abortions in the US, and we know that a growing number of people in the US are self-managing their abortions with pills at home. Today, half the country has mainstream telehealth abortion access. In other states, people can access pills through alternate routes, plus hotlines and resources for support. But there may be legal risk. These resources are here to help. For more information on abortion pills, visit Plan C.
So as you can see, we are in the business of combining the public health information that's available with creative campaigns that get it out in a way that is accessible, that is understandable, digestible for folks. And I just got a question in the chat, is it in Spanish as well? Yes, we just finished a Spanish version that we'll be releasing in the coming weeks. And we hope to translate it into a few other languages as well, and we're doing a couple more animations with the same partner. So this slide is explaining that we're not I guess what I would call your typical abortion nonprofit. We're really approaching this from not only a public health information campaign, but a paradigm shift. And we're looking to help encourage transformation of the landscape of abortion access by normalizing this self-managed method, by including it in the array of options that are available for modern abortion care. And we do that by sharing information and partnering to get the word out. So next slide. Oh, we actually skipped, sorry, we skipped the global landscape. Can we just go back to, so we also ground our work in a global context. My two co-founders, co-directors who I work with most closely were doing international work for decades before we started working together. And so they recognized the disparate nature of abortion pill availability. Abortion pills are endorsed by the WHO as an essential medication Public health experts consider them safe enough to be over the counter. They're used by millions of people worldwide every year to self-manage early abortions, and they are available over the counter in many other countries. In India, 70% of all abortions are outside of the healthcare system with pills. And in Europe, it's up to, in countries like Sweden, it's like the video said, it's up to 90%. Most of those obtained within health facilities. But you can see it's really helpful for us to ground the US conversation within a global context to understand it better. So can we advance 2 slides, please? So we are a public health information campaign. I started it with 3 public health researchers. So again, why I'm really happy to be here today to talk to you all through the lens of public health and then expanding outward. And just by we were recognizing the transformative potential of introducing this safe self-managed option in the US. So how we do that, we maintain a 50-state guide to pills by mail and telehealth. That includes FAQs, it includes links to these free medical and legal hotlines, as well as an array of other resources that we know to be available. And we also run creative campaigns to get the word out, always in partnership with grassroots organizations, always understanding if we're working in a state, if we're targeting a campaign, we're always partnering to make sure that this information is making sense and that it is presented in a way that's right for the community that it's reaching. And we're doing all this to bring it into the mainstream with a big vision of a world in which these pills are in the hands of the person who needs it. Next slide, please. So what's happening in the US? So much has changed. And I also think if you feel like, wow, I didn't even know that half the country has telehealth abortion, that's okay. It's very new. And a lot changed because of the pandemic for a couple different reasons. One, we were all going toward telehealth naturally as we were shut up in our homes. And then also the FDA lightened their restrictions on mifepristone, restrictions that we would consider political in the first place. They're not based on science or medicine. They're restrictions that were put in place and not adjusted until the past couple of years for other reasons, for political reasons. But things did change. Telehealth providers did start to come online. Half the country now has telehealth through Choice in California, Hey Jane in a couple states, Abortion on Demand, I believe, is in 22 states. And then Aid Access is an international organization that has been serving the US with pills by mail and remote support since 2018. So that is how we as researchers are comfortable saying that these abortion pills are available in all 50 states as long as the person has internet access and understands what else they need to know, understands the resources that are available to them, like the M&A hotline and the Repro Legal helpline. Abortion pills are a reality. They're not a theoretical, they're not a future plan, they're here. And there are so many resources gathering around the individual and around communities to ensure a safe, supported experience. So the Plan C guide is really the hub for all of the information that we know to be available for the self-managed ecosystem in particular, but also with links out to other options for care, other options for access. Next slide, please. So that's the part of our strategy that we call people have access, and then people know is the second strategy, and that is our creative side. That's our ambassadors of information program. That's where we are gathering volunteers. We are running mobile billboards when and where appropriate. We had posters in the New York subway system a few months ago. And then I included a few images from Shout Your Abortion, which is a totally separate organization, but we watch them closely because they are really pushing the envelope with messaging. They have billboards going up across the country with messages like "We will aid and abet," we're doing it anyway, kind of spirit of messaging. So we're watching things change so rapidly in the landscape, and we're watching people mobilize around the public health crisis and around the need to spread information and keep people safe and well in their moment of need, no matter where they live. Next slide, please. So Plan C specifically, in the past year, we've had major growth. We have had what was recently calculated to be 13 billion press hits, which I can't even wrap my head around. We've had it's now 1.7 million visitors to our website in the past year. I include this stat not to boast, but really to give a snapshot of the number of people going online looking for resources. And also out of those people, it's actually something like 580,000 clicked off the guide to find resources, whether that was telehealth or hotlines. That's a pretty substantial number when you think about the average number of abortion seekers per year is approximately 900,000. So it's happening. Again, it's real and it's happening, and people are ready to understand and ready to seek out this kind of information. Next slide, please. What about legality? This is one of the biggest questions we get asked. These are just some bullet points, especially after Dobbs. We were asked about this a lot, and the points that we circled around were basically that these bans are not based in medicine or science, and self-managing your care is not a criminal act. We hear this from If, When, How, the legal organization, all the time. Politicians must stop legislating and criminalizing healthcare. We also think a lot about that a ban is a ban, and whether it's 8 weeks or 15 weeks, it's undermining all of reproductive health care by intercepting these essential medications and by disrupting normal channels of care for an individual. Further, the self-managing is not a crime, and so many of these new bans do not actually speak to the individual. They do not actually target the individual or self-managing an abortion. So we feel like that's a really important part of the discussion right now. As we hear that abortion is illegal in a state, we need to ask, illegal for whom? For illegal to prescribe or to manage or to seek, and really understand. Regardless, we know that potential risk will fall hardest on people who already face discriminatory obstacles. So we're very sensitive to that. And that's why we always share the suite of resources, including something like the Repro Legal Helpline. And we continue to share this evidence-based health information, to run PSAs, to share out, because we know that it's more important than ever, and that we believe that we, and meaning we, all of us, still have a right to free speech and sharing information in general. Next slide, please. Finally, we talk all day, every day about this option because it is kind of misunderstood and under-recognized, but we recognize the need for all options of abortion. We recognize it needing to be available through clinics, telemedicine, self-managed care. And that also speaks to this spectrum. I think there's a lot of questions these days about what is telemedicine versus self-managed. There is a spectrum of experience that someone might seek, just as there's a spectrum of reproductive health outcomes. And I think the more that we can understand this holistically, the more that we can wrap it into existing systems, wrap it into community care so that it is treated like any other basic need. Next slide, please. And that's it. That's the basics about the Plan C campaign. Again, we really love when people get involved with sharing this information out and with the events and campaigns that we run. So our information is there, and I can share my personal information as well. Really honored to be here today. Thank you so much. Oh, there's a question in the chat. I'll wait on questions till the end.
Yeah, Amy, we're going to be doing audience Q&A at the end. Yeah, great. Thanks so much, Amy. Thanks so much for everything you're doing at Plan C. What a great organization. And thanks for joining us today. We're going to hear next from Linnea Pittman, who is a data and privacy expert at Morrison Foerster. And she's going to be discussing a little bit more about the legal side as it regards digital privacy, your data use, and your data creation. Thanks so much, Amy. And Linnea, are you ready?
I am.
Great.
Thanks, Lindsay. Hi, I'm Linnea Pittman, a privacy lawyer in New York, as Lindsay mentioned. And when Roe was overturned in June, my group started getting really worried about the weaponizing of personal information and started looking for ways to make specific practical privacy guidance widely available. We ended up building a digital handbook, Privacy Tips for Protecting Reproductive Rights, which I hope you'll look at after today's talk. The handbook offers guidance for individuals who live in a state that restricts access to abortion, healthcare providers, as well as recommendations for tech companies. But in the next few minutes, I really just hope to frame privacy in the US and give you a few key takeaways as we head into the discussion portion. So while the focus of this is on abortion, when you're talking with your friends, your colleagues, reading the newspaper, I want to just emphasize the broader context in which this decision sits. Roe v. Wade established the right to personal privacy, existed in the 14th Amendment, and it encompassed a right to abortion. Justice Thomas wrote a concurring opinion in Dobbs that really goes much further than just abortion in attacking privacy rights. He calls to re-examine other rights like the right to same-sex intercourse and the right to contraception. And these liberties that he's concerned with are largely liberties that relate to concepts of personal privacy and family life, free from unwarranted state intrusion. Next slide, please. So in the US, the focus on privacy has historically been one about particular types of data, like sensitive health information or sectors of concern. So health, hospitals, doctors, office visits would also be in that category. And then they write legislation particularly around that issue. If you're going to school in California, living in California, you might have heard rumblings that the privacy landscape in the US is really undergoing a massive shift. We're seeing states start to enact broad sweeping privacy laws that include things like notice and individual rights. And there are a lot more of these that will probably go into effect and emerge in the next couple of years with the potential of a privacy bill at the federal level too. But what I want to emphasize is that these laws are not really getting at the issue we're talking about today. These are laws really concerned with marketing and targeted advertising and giving consumers ways to understand what information businesses hold about them and opt out of certain uses of that information. So it doesn't really get at, and it won't really either restrict or help enable access to abortion in the short term. Next slide. So stepping back from the legal landscape, as technology increases access to safe reproductive health resources, it also increases the ability of law enforcement in states that are restrictive and hostile to abortion to access data that could be used in a potential prosecution. And with the Texas bounty law, we've really seen this way in which law enforcement and individuals may be encouraged to surveil their neighbors or really weaponize information. And if you think about it, once data exists, there are all sorts of uses of it that are legitimate, that are almost necessary. If you have a job, your employer needs to use sensitive information about you to provide benefits, or after a doctor's visit, information about you and that visit might need to be given to your health insurance provider. So my goal today, and in just 1 or 2 minutes, is to empower you to understand and limit the types of data that you create. We're talking here about wide swaths of data that, just by using the default settings on your phone, you might carry with you location data, search history and browser history, text messages, and all of that metadata. Next slide. So if you know someone in a state that's hostile to abortion that needs advice, or you yourself are looking to kind of understand how you could protect yourself, take affirmative steps for digital privacy, and reduce the footprint you leave that kind of permits digital surveillance, I would give you a few broad ideas. I think one of the concerns with digital privacy is that people get really overwhelmed about all of the tech and the gloss that gets put on it. But at a basic level, state enforcement is going to depend more on how many people you talk to, how you talk, and whether you're mindful about reducing this digital footprint. So a couple of things to think about are being careful about whether you talk and whether you write something down. The thing that we've seen in prosecution so far is that written information, texts, social media posts, and online searches can really be critical evidence. But if you're anything like me and you're in crisis, you often need to talk about it. So we're encouraging people to do so securely. Use platforms, some that are just built into your phone, like FaceTime or Duo for Android users, that are end-to-end encrypted and offer you ways to communicate securely without writing something down. Browse privately and delete your data. This is one of the things that even as a privacy lawyer, I didn't always do before kind of putting this handbook together. But there are easy ways to ensure that your searches and what you look for. If you're seeking out Plan C, et cetera, you can do that without leaving as large of a digital footprint behind by browsing securely, and then even if you're not able to do so, deleting your data afterwards. And finally, this seems like a basic piece of advice, but if law enforcement approaches you, or if you have concerns, call a lawyer. Exercise your constitutional right. Amy mentioned If When How's Repro Legal Helpline. We're recommending people to that resource as well. If When How is doing a great job of offering confidential and free legal advice, and will help connect people with a lawyer if you need one. So if you remember nothing else, I would leave you with that, is that even though there is no constitutional right to abortion anymore, you do have recourse, and we hope you use it. And with that kind of condensed version, I'll pass it along, and thank you for having me here today.
Thanks so much, Linnea. That's so useful. And I encourage everyone to visit the link that we put in the chat that has the data privacy handbook that she and her colleague put together. It's really great and has a lot of really, really useful practical resources available for you. So our next speaker is joining us from UCSF's Advancing New Standards in Reproductive Health think tank. Katie Woodruff is going to be discussing how we communicate about abortion, how we message about abortion, and thinking really critically about the types of language and mediums we use to discuss the topic. Katie, are you ready for us?
I am. Thank you.
Thank you.
Well, thanks, everybody. It's great to be here. I also am a graduate of UC Berkeley. Both my master's degree and my doctorate are from the School of Public Health at Berkeley. So happy to be back. Can you go to the next slide, please, Emma? Just briefly, if you haven't heard of us, ANSWER is an interdisciplinary group of social scientists at the medical school. So it's strange to have social scientists within a medical school, but it's very fruitful partnership. We study abortion, contraception, substance use in pregnancy, and a bunch of other reproductive and maternal health issues, really with a focus on being able to create evidence that will inform policy and public discourse in order to improve people's reproductive well-being. If you go to the next slide, please. I just wanted to briefly say in terms of terminology, because I know a lot of folks aren't that familiar, and I'm supposed to be talking about languaging, messaging. A person who wants an abortion can either go to a clinic to get provider managed abortion or get pills on their own. And I think this new model of telemedicine that's coming out in the last few years around abortion is a very interesting sort of middle ground. But officially right now, if you're getting pills through telemedicine, that counts as going to a health provider. And if you could go to the next slide, please, Emma, I just want everyone to know what the research is showing. While we talk about self-managed abortion, Emma, can you go to the next slide, please? Thank you. The majority of clinical abortions in the first trimester that happen within a provider setting are medication abortions now. On the other side, we try to use the word procedural abortion instead of surgical because it's not as invasive or difficult a procedure as the word surgical would imply. But within the self-managed realm, people can get and use the same medications to end a pregnancy without ever seeing a provider. And our studies have shown that using medication abortion doesn't require any in-person screening, any ultrasound, and the outcomes are very similar in terms of safety and effectiveness to provider managed. But just to let you know, as recently as last year, the most recent data we have, the majority of self-managed abortions in the US were still by these other means that are listed in the lower right quadrant. If you could go to the next slide, Emma, just to show medication abortion is very safe and effective, whether provider managed or self-managed, but most people in the US are still turning to other means, which are largely ineffective. And of course, they're quite unsafe. That's why I have the red slash through them. And that's why we really do need to be spreading the word about medication abortion as a better option for self-managed abortion. So next slide, please. How are people using digital media to spread the word on this? I just want to share a few quick examples. I'm happy to talk more about any of these. And for purposes of this presentation, all of them are in English and are US based, but there's lots in other languages and from other parts of the world as well. Just first to let you know, Teen Vogue is knocking it out of the park these days and with their coverage on abortion, but also all kinds of political issues. I highly recommend everyone follow Teen Vogue wherever you can find them. Next slide, please. But what we're finding is that a lot of the information that needs to be shared about medication abortion outside of a medical setting really comes down to person information sharing. And that requires people to be trained and understand the protocols and how to help people understand what to expect if they choose to use the pills on their own. So one thing I've been loving is online trainings. And in this particular example is from an URGE training. The group is called Uniting for Reproductive and Gender Equity. It is a youth-led organization, and they're holding these digital info shares on self-managed abortion where they teach people about the WHO and FDA protocols and help them learn how to talk about it with other people so they are empowered to go out into their community. They're really fun trainings, and I just wanted to share this. Anybody who's been a student in public school in the last 10 years has probably done a Kahoot, and this is sort of technology that's used to gamify answering questions. This is just one example that they used in the URGE training. So it's a way to reinforce what you're learning about the protocol for self-managed abortion. Next, please. TikTok has some really great and fun examples, and I want to give a shout out to Plan C, which is one of the most fun. We just sorry, my brain, accounts to follow, but also just really fun to see all the different kinds of stuff. There's people dancing to information about self-managed abortion. There's really good high quality information, and I have seen recently that TikTok has been sort of hurrying to take down some other like misinformation, but seems to be leaving a lot of the accurate ones up. Both of these are great accounts to follow if you're interested. Next slide. There's some more detailed things on Instagram where it goes into a little more detail about both the stories of people who might choose to self-manage an abortion and also what people could expect if they choose to take these pills and when they need to maybe consider going to get some medical help if something goes wrong, which is rare, but people do need to be prepared for that possibility. Next, please. On Twitter, we're seeing a lot of conversation as well. Some of this is much more policy and research focused, and this is people talking about having gone to the White House to present on the need for more access to the medications for medication abortion, and other issues. And so a lively debate there as well. Of course, a lot of trolls, I would say. Finally, I just wanted to say on the digital side, next slide, if you don't know about Yuki, this is a phenomenal phone application that has very accurate, very inclusive, comprehensive reproductive health information and including a period tracker for folks who want to use a period tracker and know that it will be absolutely private. This was developed with assistance of lawyers who were concerned about states gathering people's data from regular period trackers and being able to use it to prosecute them. So just so you know, this is a fantastic app. I highly recommend it. It's free, check it out. All right, so I wanted to just spend a few minutes talking about best practices for messaging. And if you'll go to my last slide, there's a lot on here, but I just wanted to talk it through at broad strokes. I think the most important thing for us all to walk away with and to share with others is that medication abortion is incredibly safe and it works, whether people get the pills from a clinic or on their own. The mifepristone and misoprostol regimen works 95 to 98% of the time to terminate a pregnancy completely without any follow-up care needed. And that is true whether the people are using them in the clinic or on their own. I mean, get them from the clinic. Secondly, it's really important for us all to talk about values. One of the things I was asked to talk about is how important it is to talk about abortion as healthcare. And I do think abortion is an important part of healthcare, but I don't think that's a winning argument. I think, and I should say, I studied and did a lot of work on strategic communications and public health policy issues for years in between my master's and public, and going back for my doctorate. I worked at Berkeley Media Studies Group. And I think it's really about the value. And the most important value under abortion is freedom. That's resonating with voters. It resonates with people who want to control their own pregnancies. Abortion really is the freedom ultimately to decide whether and when we have children. And so abortion with pills is giving people that freedom to manage their own bodies on their own terms wherever they may be. It's important not to frame medication abortion outside of a medical system as some kind of a last ditch option for people. A lot of people choose it affirmatively because of the privacy, because of the ability to control the timing of when they want to do it. So it's not just because there are barriers to in-clinic care. There are reasons why people might choose to do it at home, no matter where they live. A couple of phrases that are really important to normalize abortion, no matter what context we're talking about it. People have always had abortions, and they always will, regardless of what the courts or the politicians may say. This is just factual. There's records of abortion, different types of treatments and attempts of abortion going back 4,000 years and more. So we know that that's true. And given how common abortion is, statistically very likely that everyone loves someone who has had an abortion. You might not know it, but it's very likely. And that's just a nice reframe too, in terms of talking about the support and the love for people who have had an abortion and who choose to share their stories. When you are talking, if you choose to talk with anyone about the protocols, give information about how to use the pills or what to expect when using the pills, or when to be looking for what signs to look for after using them that might be a signal of need for follow-up care. Those are all very important pieces of information to be able to give someone. I'm not a lawyer and this is not legal advice, but my understanding is you are more protected in terms of what's legal to share if you convey that you are talking about approved protocols, that both the FDA and the WHO agree that these are safe and effective ways to end pregnancy. And then don't use third person when you're giving advice. So if you would say a person who wants to end a pregnancy can take 1 mifepristone and then 24 hours later take 4 misoprostol pills, hold them in your mouth under your cheeks for 30 minutes, swallow what's left, and that will start the pregnancy. I think I said you in there somewhere. I'm telling you, don't say you. So what you want is to say, this is what a person could do. You're just giving information. You're not telling that person what they should do. And then finally, I think it's really important. There are only 3 states that have criminalized or have laws to try to prevent people or to punish people who manage their own abortions. But as was pointed out earlier, there have been numerous cases where people have actually been prosecuted under other laws for trying to terminate a pregnancy. So it's very important for us all to be contributing to the idea that no one should ever have to face prosecution for making their own pregnancy decisions, whatever those may be, including abortion. I'm very happy to talk more about the messaging on this when we get to the questions. Thank you.
Thank you so much, Katie. That was a lot of really great practical recommendations. So finally, we're going to hear from Ndola Prata, who has worked for numerous years in the international context in the subject of family planning. And we're going to be go right from there into a conversation and then our question and answer portion. Ndola, are you ready to speak with us?
Yes,
Great.
I don't have slides, and I just want to tell everybody a little bit about myself. So I'm the faculty director of the Bixby Center here at UC Berkeley, Bixby Center for Population Health and Sustainability. And we do a lot of work on increasing access and utilization of services, more specifically contraception and safe abortion services. So I wanted to start by just also saying that until 2015, I was a medical director for a nonprofit organization created by faculty here at UC Berkeley that had a single intention of registering mifepristone and misoprostol around the world in countries where those 2 drugs were not registered for gynecological indications, so that countries could start use it in their maternal health programs for various gynecological indications, including pregnancy termination. So, going back a little bit on history and the differences between what I have been able to observe in the international scene and here in the US. just by starters, misoprostol is a very old drug. It has been there and was actually developed for gastric ulcers. So it's everybody has it. Both of those drugs are off patent. But mifepristone, that it has a little bit more specific indication, or most people know it for pregnancy termination, was registered in France in 1988. So most European countries already had mifepristone registered for abortion indications before the US. Now, until 2015, as I mentioned, we did quite a bit of work to bring those two drugs to a lot of the developing world, and including in places where the restrictions are sort of the legal framework for abortion is really strict, but countries would still use the harm reduction framework or the harm reduction model, so that anyone that gets the pills can call some hotlines or can go to providers, and providers can let them know exactly how to take, like Katie was explaining just before me, how to take those drugs. And this is to minimize problems and issues for not knowing how to take the drugs, but having access to the drugs. So the model of harm reduction is very simple. It's similar to what we have. Even yesterday was in the news, the San Francisco model of needle exchange in case of substance use. So clean needle exchange. So that's a similar model. So you prevent the complications from using, because we know that pregnancy terminations will happen with or without irrespective of the legal framework. Now, the issue, for example, of what self-manage means and how that plays on when in the international arena. Most of the times the word itself, self-manage, is not used, especially in developing countries, because to be honest with you, what happens with in the case of abortion is that you get a prescription, you get the pills, and you follow a regimen at home, and you come back for sort of a review and monitoring for completion, to ensure completion. So in cases like the example of Rwanda, where we actually trying to bring the services, and this is a hospital level, but bring the services to primary healthcare levels, we use telemedicine, and in many places, even without a concerted program, individuals can call physicians or providers that have the ability to prescribe, and they do so. And then the individuals will basically self-manage their abortion. But that is similar to many other conditions and diseases where you can request the drugs or go to a physician, get a prescription, and then manage the disease. I mean, it's similarly, so we don't take that as, and giving that the drugs are very safe, as you heard already, so that it's not taken as a huge deal. In many places in the developing world, mifepristone and misoprostol packaged together are actually socially marketed. So you actually don't need prescription, but you do need more information and better and correct information on how to take it. And here is where the harm reduction framework plays a significant role, and where people can go for that type of information, including where it's sold in pharmacies and drug shops. A lot of training of pharmacists and drug shop owners and sort of a drug dispensers, to ensure that anyone that purchase what we call it the combi pack, anyone that purchases the combi pack has the correct information about how to use it and what to do in case they're not feeling comfortable with the symptoms of signs that they can see. The other model that I like very much is the model of Bangladesh, where the Combi Pack is socially marketed and visits at home by community health workers, the lady health visitors, as they're called there. The individuals can get the drug directly from them, so don't even need to leave your household. And this is actually under the menstrual regulation program, so they don't call it abortion. It's a menstrual regulation program and is quite safe and effective. And those community health workers are not trained like nurses, but they do a lot of work in sexual and reproductive health, maternal health, and nutrition. So they're also used and deployed to provide menstrual regulation with medication in majority of places, including in rural areas. So the other thing that I wanted to point out that is a little bit different in the US is that in most countries, so you can categorize countries into two groups. In the developing countries, for example, where abortion in first trimester is totally on demand, or abortion is according to specific sort of characteristics or reasons for termination that are allowed within the legal framework. But those reasons that include fetal conditions, maternal health conditions, rape, incest, in some countries, underage, forced marriage, are there. And the issue that we're having is not to collect information by reason, because individuals know the reason, know which reasons are according to the legal framework, because abortion is still not on demand. And if they fall outside of their reasons, they select one reason, and that's that's what they report. So we're trying, very carefully, in the spirit of increasing the safety of abortion, not to collect that type of information, because it gives a picture that is probably not as accurate as it should. So that's one piece of data, the reason for abortion, that we have issues. The other piece that is important to mention, that it significantly affects access to services, are the fact that in many places only doctors are still allowed to do it in the district hospitals. And in addition to that, there is a conscientious objection of providers plays a significant role in access and utilization of services. So I'm going to stop here and maybe just answer questions if they come along.
Thanks so much, Ndola. That was wonderful. And what you were just discussing kind of brought up a question for us here, which is, how can we best be using and leveraging technology to reach people in difficult to access places? So I'm thinking about places in the rural US or in the international setting. This is a question for the group about what are the ways that we can be reaching people who don't have easy access to information and don't have great infrastructure supports? And do we have any kind of advantage using technology in that capacity? So I'm interested in the international context that you've been working in, Ndola, and then any other thoughts that people have about this kind of issue.
So I could start by just talking about the bare bones simple phone. Just being able to call, and phone access, as you know, is very widespread. I'm not saying that all individuals, even in rural areas, have a cell phone, but someone in the community has one. But the importance is knowing who to call. That is the key. It's not the technology itself, is knowing how to use the technology to their advantage. And that is what, knowing, for example, and like in the case of Ethiopia and Rwanda, through community health workers, pass on the information to the communities that, so I'll give you how it's translated into English from the local language. If your period is missing, do not do anything, do this, where to go and who to talk to. So don't interfere with your body, because all of that, remember what Katie showed, all of the different sort of at-home self-managed methods that lead to sometimes sort of a bad outcomes do exist. So one of the things that is part of the harm reduction with support of the technologies that don't do anything. So then you call this number and then you get information on what to do next.
I like that. If your period is missing, if it's gone missing,
Do not interfere with your body.
don't interfere with it. I love
and be careful. We're not talking about pregnancy.
Mhm.
We're not talking about abortion. And in 99% of the cases, including in the menstrual regulation sort of a banner in Bangladesh, you don't test for pregnancy, because that then you cross the other legal line that we don't want to. So you have to stay on the good side by not mentioning the words and not doing carefully sort of a language to still make sort of a determination safer.
Right. Amy or Katie, did you have any thoughts on that topic?
I think Ndola did a wonderful job of explaining how, and I think what was coming up in my mind as you described that particular approach is that each community is going to have their own way, or each network is going to develop their own methods of spreading information based on what they know to be true about the community's needs, about the trust of a method, or what someone might need to know in order to make a decision that's best for them. So I think it's not a one fits all solution. It really is a careful and steady approach to going deep within communities, as well as at the same time having these broad strokes approaches that like I was describing, kind of bring it into what we would call the mainstream. So it's a both and.
Mm-hmm.
And I think it's not just, I guess what else is coming up in it, and I can respond to a question that came to me about, does Plan C partner with groups like Las Libres in Mexico that are starting to ship pills to the US and pretty publicly serve from Mexico and run hotlines and serve people's needs from Mexico. We don't partner, we list them on our guide, and we are researching and uncovering and sharing all that is currently available. And by listing them on their guide, people are more likely to discover Las Libres, as well as all the other efforts Las Libres is doing to get the word out. And I think that's one example of the way that this kind of self-organizing is starting to happen, that the need is real, and activists and providers and everyone's kind of recognizing what their role might be in it, based on their own, again, willingness, acceptance of risk, and appetite for stepping up and taking action and making decisions based on their own principles and values, instead of what's being dictated to them by a system. So it's I guess kind of extending off that question into what else we're seeing. There's going to be a lot more of that, I think.
Yeah, that's great. So one of the questions that's been coming up in the chat is, how can people know, without potentially creating either a digital trail or some kind of physical trail about their pregnancy status, how can they know if they're within the correct window for taking pills? So how can they know they're within that 12-week window? What are your thoughts on that question? I see you got your hand up, Katie.
One of the things that research has found is that people are very accurate if you just count from the date of your last period. So the 12 weeks is when did you last bleed like a regular period? And if it's within 12 weeks, you can safely and effectively take those pills to terminate a pregnancy. The important thing to know is, if you're beyond the 12 weeks, it's not going to harm you to take the pills. It's just maybe not going to be as effective to end the pregnancy. So it's not like, again, this is not medical advice. But past the 12 weeks, there's not like dramatic cutoff of something terrible starts to happen for a person who takes those pills. It's more a reduction in the effectiveness.
Great, thank you.
Yes. Oh, no, I was just saying that the example, the reduction in the effectiveness, for example, of the two drugs, also happens when you only take one drug, which is misoprostol. In many countries where mifepristone is not registered or is difficult to get, most people just use misoprostol alone for termination of pregnancy. It's also very well studied and very good. It's not as efficacious as the combination, but it starts the process, and in more than 80% of the cases is very good for the first trimester. But sometimes you need additional drugs, and it's very easy because the additional is another 3 tablets of misoprostol, which is the treatment that we call the treatment of incomplete abortion, which with medication is also with misoprostol only.
Great, great. Oh, I've got one question coming up. So what resources would you recommend to learn which policies exist across the globe to restrict or enhance access to the miso combo? Did I get that right? So it sounds like we're looking for one of our audience members is looking for resources from a more global perspective, as opposed to just the US.
In terms of where the is registered? Sorry, I didn't understand.
What are the, I think the question is, what are the best resources for somebody interested in understanding global policies about medication abortion? What are some good resources for that?
I mean, everywhere. If you just type mifepristone misoprostol combination.
I think
That's
the WHO has a database, although I'm not endorsing it. I don't use it actively, but yeah, I would say, I mean, if you
I would
Google
start with
around,
the WHO as well.
yeah.
Yeah, but the Genuity Health Projects has done a lot of work on this, and it has maps, beautiful maps in where it's registered, and yeah. So that's another site that it's reliable and accurate.
Great. Well, then in our last few minutes, I wanted to bring it back to Linnea. We're curious, some of the more practical tips that I know that are in your handbook for people who might not have had a chance to take a look at the handbook or might not be able to. What are some of your real kind of first line go-to tips about protecting your privacy?
Sure. Yeah. One thing I didn't mention is that it's not all on individuals. I think there's a lot of like public push for companies to really step up to the plate. And there were some players that were very quick, like Google Maps said, Google publicly stated early in July that they would delete location data if it seemed like an individual had gone to an abortion clinic. And we are kind of encouraging, and a lot of lawyers and abortion advocates are pushing companies to be even more accountable, so that, you know, if you do send a Facebook message, Facebook then doesn't turn it over to law enforcement. And there are more specific laws. California has proposed a law that would limit companies in California to respond to subpoenas they might get from out of state, from states that are hostile. But to pull everything together, there are affirmative steps that you can take, and that really are just a few clicks away. So one that I really recommend is using private browsing. I use an app on my phone called DuckDuckGo. You can search for anything, and there's this kind of funny little fire emoji in the middle that allows you to delete your data. And so none of it is sort of collected. And what we wanted to do in the handbook is really provide step-by-step instructions per device. So if you use, if you've been using Google search for years and you've never thought about, you know, how much data you've kind of accrued by searching, we have step-by-step guides for you to just go into Google. You can do this on your phone, you can do this on your computer, and just delete all of that history at once. So we recommend people do that. Another thing is tracking and advertising. You can block targeted ads and you can opt out of third-party tracking. And these things are kind of default settings that you can sit down and do, and then they last moving forward. So I think privacy can seem really daunting and like a fleeting thing in our digital lives, but I just want to empower you to take a couple steps to take that back, and hopefully we'll see the market and perhaps even law follow in a better way.
Great, thanks, Linnea. So it looks like we're just a smidge over time. So I think I'm going to wrap this up right now to be mindful of everyone's time. We really appreciate everyone's participation on the panel and such a great audience turnout. And we're really excited to be able to provide what we hope has been an empowering discussion with practical, real world advice for people to be taking into their own lives and to be spreading within their networks, and around their schools, their communities, and other places. We will be sending out a recording of this, and I believe a PDF of the slides, and some of the Q&A comments that we came through that we weren't able to get to during the discussion component. So I want to thank Linnea and Ndola and Katie and Amy and everyone working here with me in the background to keep this running with all of Berkeley's wonderful technical glitches. So thank you all for joining us, and I hope you have a great rest of the day. Thank you.
Thank you.
Thanks, Lindsay.
Thank
Thanks, everyone.
you.
Thanks, Al.